We will start today the fourth session of this amazing initiative by Indian College of Cardiac Anesthesia and Indian Association of Cardiothoracic Anesthesiologists. And it has been created for a continuous academic teaching and training program for our FACTA candidates, although it is also aimed towards the teaching and training of students pursuing other kinds of courses in cardiac anesthesia, mainly the DM and the DNB programs. Today we have Dr. Satyajeet Misra, Professor and Head of the Department of Anesthesiology and Critical Care in All India Institute of Medical Sciences, Bhubaneswar. Welcome, Dr. Satyajeet, and I invite you to start your presentation. Thank you.
Thank you so much, Rahul. So a very warm welcome to all of you who have taken the time out for attending this lecture. Please excuse me because I have a bad throat, so so the voice quality is not going to be as good. I just hope that I am audible and my slides are visible.
Yes, you are, and the slides are visible.
Okay, so I'll be straight away going into the topic, and what's been assigned to me as pacemakers. Rahul has asked me to speak a little bit about both, mainly about temporary and a little bit about permanent. So I'd like to say that I do not have any conflicts of interest to declare as associated with this talk, and my acknowledgements are for Dr. Thomas Koshi, the professor and head of the Department of Cardiac Anesthesia at Sri Chitra Tirunal Institute, who has been gracious enough to share his slides on the same talk, albeit that was in non-cardiac patients undergoing non-cardiac surgery, but some of the videos have been taken from that presentation. So a lot of thanks to Dr. Koshi. So what are the learning objectives of this talk is that we'll review the indications for pacing. Because the bulk of the talk will be about temporary pacemakers. So we'll see how we set up the temporary pacemakers, because that's really our domain. We'll review a little bit about the common modes of pacing that we usually practice in the intraoperative environment. And we'll end up with a few troubleshooting exercises, which will be in the form of quizzes, which the FIACTA residents should attempt to answer. Now, when you look at what is the definition of pacing, it's nothing but application of an external current with the aim to depolarize the myocardial cells, either in the atria or in the ventricles, because the heart itself is not able to generate the current internally. Now, I'm assuming that there is a background knowledge of the conduction system, so I'm not going to go into the details of the conduction system. So we'll move into the topic directly per se. Now, majority of the pacing that's done in the field of cardiology is permanent pacing, but what's in the realm of anesthesia and where anesthesiologists are often called upon is when either the transvenous pacing wires are being put in patients with higher rates of AV block, or where you have transcutaneous pacing in the OR, or mostly epicardial pacing as practiced after cardiac surgery. And because all of us are dealing with epicardial pacemakers, so that will form the crux of this talk. So when you have, if you look at the schematic diagram after the heart surgery or the cardiac surgery is over, the surgeon puts in the wires commonly in the atria, 2 wires in the atria and 2 wires in the ventricle. That's in the right ventricular. The surgeon will select a small area of the muscle near the outflow tract to put the bipolar leads. Sometimes the surgeons will just put the ventricular pacing wires. For example, if a patient has got atrial fibrillation, there's no point in putting an atrial pacing wire. So sometimes the surgeon will put just the ventricular pacing wires. Commonly, however, the atrial as well as the ventricular pacing wires are inserted, and then they are sort of brought out through the skin, sutured onto the skin, looped so as to prevent accidental dislodgement. And you have a lot of leeway once you loop these wires, then they are inserted into the cable, and this cable is hooked on in the pacing box, which has got the slots for both the atria as well as the ventricle, and that's how the pacing is initiated. So for the temporary pacing equipment or the temporary pacers, we essentially have the pulse generator. Now most of it comes from Medtronic. So the pulse generator is nothing but a small battery powered medical device capable of generating small direct currents. I mean, it's important to note that it's battery devices, and these are not powered by the mains, because if you are powering from the mains, then you'll have alternating current and that can fibrillate the heart. So you need direct current, and that comes from batteries. So these are small battery powered devices, and their job is pacemakers. Their principal job is to stimulate the heart to in an effort to depolarize the myocardium to generate a cardiac output. So they either restore the rhythm, but commonly as we apply it, they are for rate generation. Mostly, we don't deal with single chamber pacing boxes. We deal with dual chamber pacing boxes, which are capable of pacing, sensing and pacing both the atria and the ventricles. So you can see the small loops here that is sutured onto the myocardium or to the atria, and then through these needles, it's brought out from the skin and then anchored onto the skin, and then looped and then connected to the pacing box through the cables. So that's the essential equipment for your temporary pacemakers. So you may have many types. Some of them, I mean, depending on the models, but these are the common type that comes from Medtronics, and the cost of the box will be around 2 to 2.5 lakhs. So you need to be careful about how you maintain these pacers, because they're very important for patients, especially after coming off cardiopulmonary bypass. Now, there are two ways to pace the heart. You can have unipolar pacing, but these pacers have gone out of fashion, so they are no more there. Where you have a single wire, which the distal tip serves as the negative pole, and the positive pole is within the body of the pulse generator itself. And these unipolar pacers used to generate a big electrical stimulus on the heart, as can be seen in the ECG spikes. But commonly we use these bipolar pacers where the negative as well as the positive poles are just separated by a gap of 1 to 1.5 centimeters, and both are at the heart, or either one is at the heart and the other is at the skin, and they are brought out and then connected to the pacers. So these will be small pacing spikes, as can be recorded on the ECG. So when you're looking for the pacing spikes on bipolar leads, your best bet would be to go for lead 2. That is on the rhythm strip. You can see the small pacing spikes, or if you go for the lead V2 to V4, then you can see these pacing spikes very clearly on these leads. So if you're running a 12 lead ECG, you look for lead 2, V2 to V4 to see this short pacing spikes. Now, coming to the indications for pacing, mostly we deal with conduction issues post cardiac arrest. Either it may be sinus bradycardia or higher rates of AV block. You may have complete absence of any rhythm, that's arrhythmia, or you can have various junctional idioventricular rhythms or various arrhythmias. So whatever be the rhythm abnormality, whether it's an arrhythmia or absence of rhythm, we need some sort of temporary pacing. Now, remember the indications for temporary pacing. You can't keep a temporary pacemaker indefinitely applied onto the patient. So usually within 7 days, if you're not able to wean the patient off the temporary pacer, then probably that's an indication for putting in a permanent pacemaker. So temporary pacing is generally not applied beyond 7 days. We need to know a few terminologies before we go per se into looking at the settings of how to set up a pacer. So what is to pace is nothing but to deliver an electrical impulse to the heart. And how it is done is by giving out a small pacing spike, which is basically the stimulus from the pacemaker, and that's captured on the monitor as a short vertical blip, either on the monitor or on the ECG. And the duration is very short, it's around 2 milliseconds. Capture is when your pacing spike is able to depolarize the heart, and you either see a P wave in the atria or the QRS complex, which follows the pacing spike. You know that there's a capture of the electrical impulse. And pacing threshold is how much current you need to depolarize the myocardium. So if you're requiring very high levels of current, probably it may be because of various factors, for example, hypertrophic musculature, or there's a lot of myocardial edema, the effect of electrolyte imbalances. If you're having potassium disturbances, it's not going to be very easy to pace these hearts, or even the pacing wire position. And that's usually seen after a few days. Say after 3 or 4 days, your threshold for the current needs to go up, because fibrinous crusts have formed on the tip of the pacing wires. So that will increase anything that increases basically the impedance will increase the pacing threshold. What's sense is whether the pacemaker is able to sense the native electrical activity. So how sensitive is the pacemaker to detect the native electrical activity? And this is important because if there is native electrical activity, then that should be allowed rather than the pacing activity by the pacemaker. So these are the common terminologies that you will always come across when you're dealing with pacemakers. So it's important to understand this terminology. Now, the two basic modes of pacing are basically you either pace the heart in an asynchronous mode. So regardless of whatever happens to the native electrical activity, the pacemaker is going to deliver the electrical stimulus and pace the heart. The other is when you have kind of a demand pacing, which is usually the practice. And the demand pacing is that the pacemaker senses the intrinsic electrical activity of the heart and delivers an electrical activity only when the intrinsic activity is absent. So this is basically the demand mode. The demand mode is usually preferred as it avoids competition with the patient's own heart rate. So think of it something like a pressure support ventilation. So if the patient is not breathing, then the ventilator will deliver the breaths. But if the patient starts breathing at any point of time, then the ventilator stops delivering the breaths. So it's something similar. So here, if there is no inherent electrical impulse being sensed by the pacemaker, then it's going to deliver these pacing spikes, and then it's going to pace the heart. But the moment the pacemaker senses that there is native electrical impulses generated by the heart, it stops pacing. So if you set a demand rate of let's say 70, then the pacemaker, the 70 beats per minute will only kick in once the patient's de novo heart rate falls below that. As long as the patient's own heart rate is above that 70 beats per minute, the pacemaker will stay silent because it's sensing the electrical impulses. The other thing is that you have the asynchronous mode. This is like putting a patient spontaneously breathing patient on a complete CMV mode or a volume control mode. So whether the patient breathes or not breathes, the machine is going to give the predetermined tidal volume at the set rate, whatever you have set. So similarly, something like that happens here. Whether the patient is generating an inherent electrical activity is of no consequence to the pacemaker. So the pacemaker will keep on delivering the predetermined impulses at the set time. So here you can see that there's a de novo electrical activity of the patient. There's a nice P wave, beautiful QRS complex. It doesn't matter to the pacemaker. The pacemaker is delivering some impulse here. Pacemaker is delivering some impulse here. So here there's an impulse, and that generates a pacing spike followed by a QRS complex. But here there's a nice QRS complex, but still there's a pacing spike that comes in somewhere on the peak of the T wave. So the danger with that is that you have a greater risk of the R on T phenomenon, or something like that. When the ventricle is trying to rest in the phase of repolarization, the pacing spike will attempt to depolarize the myocardium, and that can lead to malignant arrhythmias. So if you have a pacing spike that falls on the T wave, then that's asking for trouble. So that's the problem with asynchronous modes of pacing. Now come to the settings per se. You have the box that looks like this. This red button tells you that anytime there's a loss of sensing or something, you can always push this and initiate emergency pacing. So you have these three big knobs here on the top chamber, and then the bottom chamber, there's one knob. So let's look at each of these knobs. So the first knob is for rate, and that's something that you need to decide for each patient. What's the ideal rate that will give the best cardiac output? And the next two knobs are the output. The output we discussed. What the output exactly is? It's the amount of current that you need to deliver to the myocardium in order to generate a complex, either the P wave or the QRS complex. So by default, the output, when you switch on the pacemaker, by default, the output is somewhere around 10 milliamperes for both the atria as well as the ventricle. Should we leave it at that? No, ideally we should try to find what is the output for each patient, for the atria as well as for the ventricle. And that's a good thing to do because it preserves the battery life. If you leave the patients with high output, chances are that the battery life gets exhausted. And so so it's always a good idea to try and find what's the minimum current that's required to generate a QRS or a P wave in the event there is no de novo myocardial activity. Then the third knob is the sensitivity. So sensitivity, we talked about sensitivity, and that was nothing but the minimum voltage that the pacemaker is able to sense either for the atria or for the ventricle. And in response to that, it doesn't deliver an impulse. So for the atria, it's around 0.4 millivolts, and for the ventricles, it's around 2 millivolts. Then there are other settings. There are the time delays. Now, if you can look here where this big black arrow is pointing, this is something called a PVAF. I'm sure most of you would have never paid much attention to this, but these are important settings. I'll be speaking about these settings in greater detail in the subsequent slides. But these are important settings because they establish the important time delays that is required for the optimal functioning of the pacemaker. So you have an AV interval and you have a PVAR. Now, the only reason I'm showing you these two settings here is that you can see there are two stars next to the settings, and that only comes when you have manually changed the settings. In the automated factory settings, it will not, the stars will not come. They will only come if you are trying to manually change it, and that indicates to the user that these settings have been changed manually. Okay, so let's look at each of these things. So we discussed that capture means that the vertical pacing spikes should be able to generate either a P wave or a QRS complex. If it's not doing that, that means that the current is simply ineffective, and you need to step up the current to generate sort of generate the QRS complex, which will give the cardiac output. So how do you decide on how much current is ideal? So let's say, look at this strip. So here, each of these is a paced beat. You have this pacing spike followed by a QRS complex, a pacing spike followed by a QRS complex, and that happens for all the beats. So you start off with a situation where you have paced beats, and you see what is the current which is there for that. Say, for example, this is for the ventricles. So we are setting the ventricular output. So at this, it reads 3 milliamperes. Then you have to step down. You have to slowly step down. Say from 3, you come down to 2, and from 2, you come down to 1. And at this point, you see that this is not generating a QRS complex anymore. And so there's a loss of capture at this stage. So this is the minimum that is acceptable, and you need to set a current at least 2 to 3 times that. So if you're losing this capture at 1 milliampere, you need to set a current of at least 2 or 3 milliamperes. So that is the one that will reliably give you that current will reliably depolarize the myocardium. So this is how we set the current. So we'll just show a video of that. Now ignore these reflections on the monitor. So this is, you can see that this patient has got the inherent intrinsic electrical activity, and you can also see the pacing spikes. Now the pacing spikes are deliberate because I have sort of increased the rate, and it's now competing with the patient's own rate. So if I want to see what's the ideal current for this patient, I will try and go up beyond the native rate. Say if the native rate is 100, I will go to 110 or 120. It's always a good idea to do this on the cardiopulmonary bypass, because you see, because there is competition, there's loss of AV synchrony, and these you can see this by this Canon AVFs on the JVP. There'll be a low cardiac output on these patients. So don't do these things off bypass. It's always a good thing to do before you come off bypass. You should set this output as well as the sensitivity. So now I have okay, we'll just move forward. Okay, so I'm sort of decreasing the output. This is the ventricular output, and I have brought it down to 1 milliampere now. And you look what happens on the screen. So there is no more paced rhythm. So at 1 milliampere, the pacer will not be able to deliver an electrical impulse. So your pacing threshold is 1 milliampere. So you need to keep up the minimum pacing output of at least 2 to 3 milliamperes. So that's the way you set your pacing output. Come to the sensitivity. Now, once you have decided that your pacing output is say 3 milliamperes, again go into an asynchronous mode. But the advice here is, if you're looking at the sensitivity, dial down as compared to the native heart rate. So if the native heart rate is, let's say 80, come down to 70. Put the patient on an asynchronous mode. Okay, so you dial up the sensitivity. So once you dial up the sensitivity, the pacemaker will become insensitive to the inherent electrical signals that is generated by the heart. So if, let's say, for example, these are the QRS complexes that are generated by the heart. I set a sensitivity here. That means I'm basically telling the pacemaker that if the electrical impulses are more than 2.5 millivolts for the QRS complex, only then detect it and inhibit pacing. So I'm telling the pacemaker basically to ignore these QRS complexes which fall below this bar that I have set of 2.5 millivolts. So what happens is, even if the patient is having these inherent electrical impulses, the pacemaker fails to recognize these impulses because I've set the sensitivity too high. Similarly, for the atria, if I am telling the pacer that set an atrial sensitivity of 1.5 millivolts, even if there are inherent atrial complexes, the pacer is not going to be able to recognize these complexes simply because I have set the sensitivity too high. Think of it like this fence. So when you have this fence, you're not able to see, if it's too high a fence, you're not able to see what's on the other side of the fence. But if you lower the fence, so if I start lowering this below this, I'll be able to see what's on the other side of the fence. So probably if I lower this bar for the ventricular complexes from 2.5 to, let's say, 1.5 millivolts, I'll be able to pick up more of native ECG signals. And once the pacer senses these ECG signals or these QRS complexes, then it will go into the inhibitory mode. It will stop firing an output. And that's very important for the synchronous pacing of the patient. Similarly, for atria, if I set the sensitivity to lower than 1.5 millivolts, say around 1 millivolt, then I can jolly well pick up these atrial complexes. So the way to do that is you keep on dialing the sensitivity up, make it asynchronous, so that the pacemaker is the only one that's firing continuously. Then you start reducing the sensitivity to a point where you lose the pacemaker output. And at that point, that is the sensitivity from where you reduce it by another half, and you set the sensitivity for the atria to around 0.5 or 0.4 and 2 millivolts for ventricular leads. So this is by default, it's usually set correct. However, you can still find out for each patient, you can individually find out. And that's again a good thing to do, because it tells you that if you have adjusted the sensitivity properly, it tells you that if there are inherent electrical signals, the pacer is going to be effectively picking up these signals and stop pacing the heart at that time. Okay, now let's come to the refractory period of the dual chamber pacemakers. I said that there are two important time delays. One is the AV delay, and the other is something called the post-ventricular atrial refractory period. Now, AV delay, we all know that after an atrial impulse is generated, the pacer sets a time delay of a few milliseconds, say 120 to 200 milliseconds, and after which only the ventricle is depolarized. So between this time, there'll be no depolarization of the ventricle. There is another important time delay called the post-ventricular atrial refractory period, or the PVAR. Now, what exactly is the PVAR is? It's something that prevents sensing of any retrograde P waves, because we know that during the time of coming off from the cardiopulmonary bypass, there can be a lot of conduction abnormalities, and one of the conduction abnormality can be a retrograde P wave. Now, the moment if you're not preventing sensing of that retrograde P wave, again the response to that P wave will be another QRS complex. So it will set off a loop tachycardia-like syndrome. So you have to prevent that. And the important caveat to that is, if you set an excessive long, post-ventricular atrial refractory period, it will lead to conduction blocks. So if you set too short a period, it will lead to tachycardia. If you set an excessively long period, it will lead to. How do we do that? So I don't know what's the best refractory period for a particular patient as far as the AV delay is concerned, or as far as the PVAR is concerned. Thankfully, the machines are intelligent in the sense that these functions are automated. So look at this heart rate. At a rate of 82, the AV interval is around 160. I keep on increasing, the AV interval automatically comes down to 150. I keep on increasing further, the AV interval has come down to 140, and I keep on increasing further, the p-VARP has come down from 300 to 250 milliseconds. So it's a good idea of not trying to manually do this yourself, because we are not somebody who is trained in electrophysiology and will not know what is the best AV interval or what's the best p-VARP period for these patients. So the best thing is let the machine function decide it, and that's basically rate dependent. So you go up on the rate, automatically these things will come down. If you're very sure of what the settings are, then you can play around, you can manually do that, but then you might be endangering this patient more. So let it be determined by the rate. These are all rate responsive. So once you change the rate, these things automatically change. Okay, now let's come to the codes. So we have the two important societies. One is the North American Society and one is the British Pacing and Electrophysiology Group. So they formed the NBG code, which was revised around 2002. So there are 5 positions. You're all conversant with this. So the first position is the chamber paced. O means there is no chamber that's being paced. A means it's the atrium that's being paced. B is the ventricle that's paced. And D means both the atria and the ventricle are paced. The chamber sensed is, again, O refers to there's no chamber that's sensed. A refers to the atria being sensed. B refers to the ventricle being sensed, and D refers to the sensing of both the atria and the ventricle. Now, what's the response to the sensing? If you have O, it means that there's no response to the sensing because there's no sensing. I is inhibited. So if there is an electrical impulse that's sensed by the pacemaker, it's going to inhibit firing of an external impulse. So the response to sensing of a de novo electrical signal is it's going to inhibit firing of the pacemaker. T is triggered. Now, the way we understand triggering is the as applied to triggering, present day triggering is mostly AV delays. So in response to an atrial sensing, whether the pacemaker applied to older modes, it was sometimes used to check whether the pacer is able to detect say an atrial signal. So for every P wave that it detects, it will trigger another. It will get triggered, but it's no more practiced in the modern day pacemakers. So triggering means whether the ventricle whether the pacer is able to trigger an AV delay or not, and that's important in a few modes. We'll discuss how. Dual means what is the response? Is it doing both? Is it inhibiting a particular chamber from pacing, from getting pacing impulses by the pacemaker, as well as is it triggering? So triggering an AV delay. So dual means whether it's doing both or not. This thing is not a feature of temporary pacemakers. Temporary pacemakers, essentially, these are the 3 positions that are important for temporary pacemakers. That is the chamber paced, the chamber sensed, and the response to the sensing. For permanent pacemakers, there's something called rate adaptive feature. Now, rate adaptive is O is, again, you don't have a rate adaptation, and R is you have rate adaptation. Rate adaptation means, say we are sitting and listening to this talk. So our heart rate is at a basal heart rate of, let's say, 70. But the moment we get up, we go out in the evening, we take a walk or we play badminton or something, obviously because of the exercise, the heart rate is going to go up, and that's a physiological adaptation. Similarly, for a patient who is pacing dependent, the pacemakers also sense this change in the patient's activity or the patient's breathing patterns and increase the patient's rate depending on certain algorithms, how much the rate should go up, how fast the rate should go up. So that's a rate adaptiveness that is present in the advanced permanent pacemakers. We'll not be discussing more on this. Position 5 again is not applied to temporary pacemakers. It basically refers to multi-site pacing, whether you're pacing one or both the atria, whether you're pacing both the ventricles. This is sometimes seen in CRT devices. So we'll not go for this anymore because this is not applied to temporary pacemakers. Coming to the modes, we have various modes. We have single chamber modes, namely single chamber modes for the atria. That's the atria is paced, the atria is sensed, and the response is inhibition of the pacemaker output when you're sensing atrial impulses. Once you put that into the asynchronous mode, it becomes AOO. Similarly, for the ventricle, if you have a synchronous as well as an asynchronous mode. You have dual chamber modes. You have the DTD mode, the VDD mode, the DDI and the DO modes. Commonly intraoperatively, we use either the DTD or the DO modes. Some of the modes are tracking. I'll tell you what tracking is. So you have the DTD mode or the VDD mode, which are tracking modes. The non-tracking modes are the DDI and the DOO. So the atrial pacing, the single chamber pacing, if you're putting just the atrial pacing wires, it's never a good idea to just put atrial pacing wires because of the high incidence of conduction block in these patients following cardiac surgery. But if the patient just has a sinus node dysfunction, meaning it's not able to generate a good P wave, but there's no problem with the AV conduction system, then you can jolly well go in for atrial pacing. The advantage is because the pacing now comes from the supraventricular chamber, that is the atria, your AV synchrony is preserved. The disadvantage is obviously when your conduction pathway is deranged, like in higher degrees of AV blocks or in atrial fibrillation, then it makes no sense to put in atrial pacing wires. So it can be synchronous. So you have this pacing spike. When the pacer doesn't sense an atrial impulse, it gives a pacing spike, and that leads to a P wave. And then the conduction pathway being normal, it gives rise to narrow QRS complex. Here a P wave is sensed, so there's no pacing spike that is given out. And then again, so see, one of the important thing is once the pacing spike is given here, the pacemaker is going to wait for a predetermined time interval. So from here, you look at these boxes 1, 2, 3, 4. Okay, so at the fourth box, it senses that there is no, it senses that there is an impulse here, and it doesn't deliver a pacing spike. Exactly, it will wait for the same time delay. So again, from here you see 1, 2, 3, 4. It waits for the same time delay, and here it senses that there is no P wave. Again, it will give a pacing spike. So the pacemaker has time delays for the atria as well as for the ventricle. So it will wait till a predetermined time, which is fixed. And once it senses an impulse, it doesn't fire. If it doesn't sense an impulse, it fires. So this is a very important concept, that there is a time delay that the pacemaker has for detecting an impulse. So it will just wait around that time for a small fraction of a second, and if it detects the impulse, it will not fire. Once you switch that synchronous mode off, irrespective of whether a P wave is generated or not generated, say for example, in this graph, there is no such thing, but here you can see that there's a pacing spike followed by a P wave. Now the thing here is, even if there is a native P wave, it is not going to be sensed by the pacemaker because you have switched off the second function, that is the sensing function. So it is just going to fire at the predetermined time interval. So 1, 2, 3, 4, 5 boxes, it fires at the fifth box. Again, 1, 2, 3, 4, 5. So it fires at the same time. Again, 1, 2, 3, 4, 5. So it just fires repeatedly at the same time. It will fire repeatedly and generate the P wave, which will then lead rise to the QRS complexes. Similarly, for the ventricular single chamber modes, for the ventricle, you have the synchronous modes. That means that the pacing spike generates the QRS, but when there is a, see, again, it's waiting for the same time gap. So here, from here, 1, 2, 3, 4, 5, it waits here. It doesn't detect a QRS complex, and then it paces and then generates a QRS complex. Again, it waits for the same time gap, and if it detects that there is a QRS complex, it doesn't give an impulse. Again, the timer is reset to start from this QRS complex, so it will wait for the predetermined time, and if it doesn't detect a QRS complex, it will fire here. So that's what it does in the synchronous mode. In the asynchronous mode, irrespective of the fact whether there's a QRS complex or not, the ventricle will, the pacer will keep on firing at the same predetermined time interval. So here is 1, 2, 3, 4. Let's say nearly 5 boxes. So here it's also 1, 2, 3, 4, and nearly 5 boxes. 1, 2, 3, 4, and 5 boxes. So it will just keep on firing at the same predetermined time interval, irrespective of the fact whether a QRS complex is generated or not. It will not change the firing sequence. If this was a VVI mode, suppose here is a QRS complex, the next timer will be reset from this QRS complex, and the pacemaker will wait for the predetermined time interval from this QRS complex. Okay, so The problem with the ventricular pacing is that there is a loss of AV synchrony, because the atria may be firing at a different rate, the ventricle may be firing at a different rate. Imagine a situation where the mitral valve or the tricuspid valve is open and there is an atrial contraction at the same time a ventricular impulse is being generated. So you can have an AV valve regurgitation because part of the blood volume is going back to the atria. You can have a low cardiac output and all those things. So the pacemaker syndrome is something which occurs because of the AV desynchrony due to the loss of the atrioventricular feedback. And usually it's seen in the ventricular modes. And these patients can go to low cardiac output and the AV valve regurgitations. And the symptoms will be neurologic. So they'll have syncopal attacks, they'll have palpitations, orthopnea, and so on and so forth. And the features will be like tricuspid stenosis or tricuspid regurgitation. You'll have raised JVP, you'll have ascites, and so on and so forth. So that's what the pacemaker syndrome is. And the treatment to that is, if you have a single chamber pacemaker, you have to go in for a dual chamber pacemaker. So the best way to do the pacing is you avoid the VT synchrony by putting in a DDD pacing. The DDD pacing is something that has a tracking mode, and this mimics the normal conduction. So you have a better AV synchrony and you have a better hemodynamics. So the atria can be both paced and sensed. Similarly, the ventricle can be both paced and sensed, and that can give rise to either the paced P waves or the paced QRS complexes. Now, let's look at what happens when you set a patient on the DDD mode. So you have a patient where the surgeon has put in the atrial wires and the ventricular wires, and you set a DDD rate of, let's say, 80. Okay, now once I set a DDD rate of 80, the patient's heart rate, intrinsic heart rate is, let's say patient's heart rate is around 90. So obviously the patient's heart rate is higher than the set rate of 80. So 80 is basically a backup rate, but the patient's own heart rate is 90. Okay, so obviously the pacer will not pace the atria because it's sensing that the atrial rate is higher than the set rate. So the pacer is not going to pace the atria. It will now start the AV delay. And once it starts the AV delay, it will see whether the ventricle is depolarizing at the same rate as that of the atria or not. If the ventricle is not depolarizing at the same rate, the ventricle is, suppose it doesn't pick up a ventricular impulse or ventricular QRS complex at that time, it doesn't sense it, it will pace the ventricle. And what is the rate at which it's going to pace the ventricle is not 80, but 90. And that's because of the atrial tracking. So on the DTT mode, with the atrial tracking on, the pacer tracks each of these atrial impulses. And if there is no ventricular impulse, after the predetermined time delay, it will start pacing the ventricle at the same rate as that of the patient's inherent heart rate of 90 beats per minute. So then it preserves the patient's AV synchrony in a much better fashion. What happens if the patient's heart rate falls below 80? Then it just goes into the pacing mode. So it paces the atria, and then it will see whether it's, again, it will wait for the predetermined time interval, see if there is a ventricular impulse. If there's no ventricular impulse, it will pace the ventricles as well. So you can have 4 different types of pacing possible in a patient with a DDD mode. The first is the situation where you have no pacing. So it's just sensing the atria, it's sensing an P wave, it doesn't pace the atria. It waits for the time delay, that is the AV interval. Then it waits for the ventricular depolarization to happen. If that happens, then it senses the ventricular depolarization. So there is no activity here. So there is no pacing. So it's just A sense and B sense. Look at the other one. Now there is an intrinsic P wave. So it's sensing the P wave. So there is no pacing spike here. But after the predetermined time interval, it doesn't sense a QRS depolarization. It doesn't sense a QRS spike. So it gives a pacing spike and generates a QRS complex. So here it senses the atria, that is A sense, but paces the ventricle. So A sense, B pace. Come to this situation. Here again, from this, it starts the time delay and waits for the atrial impulse to generate. If it doesn't see the atrial impulse, if it doesn't sense the atrial impulse being generated, it will pace the atria. So that is A pace. And it will again wait for the time delay, that is the AV interval, wait for the ventricular QRS complex to be generated by the patient's own myocardium. If that doesn't happen, then it again paces the ventricle. So that's A pace, V pace. And the last situation is Again, after the predetermined time delay, which, so for the atria, it starts from here. From the predetermined time delay, it will again wait for the atrial impulse to happen. If that doesn't happen, it will pace the atria. Again, it will wait for the time delay, that is the AV delay, and wait for the QRS impulse to generate. If that generates, then it's not going to pace the ventricles. So based on the type of patterns, you can have 4 different types of patterns. You can have A sense, V sense, in which case there's no pacing. A sense V pace, that means that the atrial tracking, and that will happen at the same rate as that of the atria. A pace, V pace, which will happen at the rate that you have set the pacer in, and A pace, V sense. So A pace, V sense is again going to happen at the rate of the pacer, because you are essentially sensing the you are essentially pacing the atria. The VDD mode is basically the ventricle is paced, both the chambers are sensed, and there are 2 responses. The 2 responses are that here you don't pace the atria. So what is the atrial response? The atrial response is to set off the AV delay, and the ventricular response is either to pace the ventricle or to inhibit the ventricle. Pace the ventricle is when you're not getting a ventricular impulse by the pacer, and inhibit the pacer is when you're getting the ventricular impulse from the patient. So it's basically in A sense V pace mode. So where you're sensing the atria, you're not pacing the atria, you're only sensing the atria. You're starting the time delay, and you're again pacing the ventricle if there is no inherent ventricular activity. So you might ask, what is the what is the advantage of such a situation? So the advantage in such advantage is that if your patient has a sinus rhythm but has got higher grades of AV conduction, so it's and you want to maintain some sort of AV synchrony, so it's a good idea to sense the atrial pacing and start the AV time delay, and then pace the ventricle if there is no ventricular inherent ventricular activity. So it's useful in situations where you have adequate sinus node functions but higher grades of AV conduction abnormality. So in that sense, it's quite good, but it's not a very common mode that we practice intraoperatively. However, it is important that we understand how the mode works, and therefore, for completion's sake, I have put this mode in. DDI mode, frankly speaking, I've never tried this mode, and to me, this mode is the most confusing mode. So I'll not delve much on this. This is just think of it as the atria and the ventricular pacers are working independent of each other. So there is no point in me trying to explain this to you, because it's quite confusing and difficult to understand. The last thing is the DO mode. Basically, it's a non-tracking mode. And here you are not sensing any chamber, and therefore there's no response to that sensing, because there's no sensing. So you're just pacing the atria and the ventricle. So you have on the each of the pacers, you have this emergency button. If you push that, it goes into the DO mode, provided you have both atrial as well as the ventricular wires. Or if you put a magnet on the patient, so if you're putting a magnet on the patient, then you are going to essentially convert each of these synchronous modes into the asynchronous modes. When you have an ICD, that will lead to suspension of the defibrillation function. It's important to remember that there will be no suspension of the pacing function in the ICD. So your synchronous modes in an ICD will still work as synchronous modes. It's only the defibrillation function that will be suspended. Few last things that I would like to touch upon is one thing that I said is the rate responsiveness, which is a feature of permanent pacemakers. It's an interesting thing. It's very useful in patients, say with inherent rate abnormalities like in sinus node dysfunction, 6 sinus syndrome, and so on and so forth, who are not able to mount rate responsiveness in proportion to their physical activity. So they have exercise intolerance whenever they are attempting something. So basically, rate responsive is, see this rhythm strip. Here it's pacing at a rate of 75, probably when the patient is at in a basal state. And when the patient's activity level increases, the same pacer starts increasing at an increased rate of 100 beats per minute. So how it does that is, there are sensors that are capable of detecting motion, either accelerometer, which is the most common thing that these rate responsive pacers have, or there are some pacers that can detect changes in the minute ventilation. So obviously, if the patient is having fever, if there's hyperventilation and all those things, then also the patient's heart rate should go up, and that's how it goes up, by detecting changes in the minute ventilation. So this information is usually fed into the algorithms, and these identify how much change should be there in the heart rate, and over how fast this change should be affected. and that's how the rate responsiveness happens. Please remember, it's a feature of permanent pacemakers and not that of temporary pacemakers. So there's an interesting algorithm, and if your patient needs a pacemaker, again, this is for permanent pacemakers. Now you need to see what is the problem with the patient. If the patient has atrial arrhythmias, then you need to see whether the patient has got chronic arrhythmias, like say atrial fibrillation or flutter. And then the next call is whether the patient has whether patient has got problems in rate responsiveness. If the answer to both is yes, you put in a rate responsive pacemaker, but in the ventricular pacing, it goes into ventricular pacing. It makes no sense to pace the atria in such cases. If the answer to the rate responsiveness is no, that means the patient is able to mount a rate responsiveness, then you just put in a single chamber ventricular pacemaker. So if the patient is having paroxysmal atrial arrhythmias, that means that PSVT or something like that. Again, if the patient is having rate incompetence, you put in a dual chamber pacemaker with the rate responsiveness. If the patient is not having a rate incompetence but has paroxysmal atrial arrhythmias, you put in the simple dual chamber pacemaker. Now, if you look at the other extreme angle of it, the patient is having a sinus bradycardia. Then again, ask the same question whether the conduction pathway is intact. If yes, again ask the same question whether the patient has got rate incompetence. If the answer to that is yes, then just put in an atrial pacemaker with the rate responsiveness. If the patient is not chronotopic, doesn't have rate incompetence, then you just put in a simple atrial pacemaker. This is rarely ever put. Nobody ever just will stick his money or neck out and just put in a simple atrial pacemaker, especially when they're putting in the permanent pacemakers. If the conduction node is not intact, then the patient, again, whether he's rate responsive or node, determines whether he gets a DTT pacemaker with a rate responsive feature or just a dual chamber pacemaker. Coming to the other types of implantable devices, we have, apart from the simple pacemakers, you can also have AICD devices, that is the automated implantable cardioverter or defibrillator. You can recognize them by the thicker wires, which are capable of anti-tachycardia and anti-shock shocking functions. And you have these CRT devices, which will have a third lead in the coronary sinus, and that's to pace the left ventricle synchronously as the right ventricle. And you can also have rate responsive CRT devices. So these are the various type of permanent pacemakers or AICD devices that you may see patients having. And once you do that, you need to know whether so there are certain things that we need to see in these patients. What has been the indication for putting in the pacemaker or the ICD in the first place? What is the type of the pacemaker or the ICD? If it's an ICD, the device interrogation time, if it's more than 6 months, then it should be interrogated. If it's a conventional pacemaker and the device interrogation has been done more than 12 months prior, then it should be interrogated once more before you jump in for anesthesia. And if it's a CRT device, then they are saying that if it's more than 3 months, anytime more than 3 months, then the patient needs another interrogation again. Determine if the patient is pacing dependent. So the pacing burden, if more than 40% of the P waves or the QRS complexes are preceded by a pacing spike, that means that the patient is pacing burden, or the ECG is predominantly a paced rhythm. Assess the symptoms of the patient, whether the patient is having symptomatology like syncopal attacks or palpitations and so on and so forth. So that means that there is some problem with the pacemaker, so it needs a proper assessment before you plan for your anesthesia. And the intraoperative considerations are that, like I showed you, that these synchronous modes need to be changed into asynchronous modes. So you can do that, either pre-program it by the cardiac technologist, or if there is no time, you can do that with a magnet placed on the patient. Problem is, the moment you remove the magnet, the the pacemaker will come back into the synchronous modes. And that's a problem because there can be a variety of electromagnetic interference, either in the OR by virtue of cauteries, or if the patient is going for MRI, or if the patient is having something like an ECT procedure, or the patient is having something like an extracorporeal shock wave lithotripsy. All these send out various kinds of electromagnetic impulses, and they can interfere with the working of the pacemaker. So these are the considerations. And now let's come to the last part where I want some participation from the residents. Can you tell me what, anybody can unmute yourself and tell me what the problem is, or is there a problem in the first place? If there's a problem, what is this problem? So obviously there are some pacing spikes. Okay. And you can see that here there is a P wave and there is a QRS complex. Here also there is a QRS complex, but even if there's a P and the QRS complex, there's a native electrical signal here. There's still a pacing spike that falls on the T wave. So that means that the pacer is not sensing these QRS complexes properly. So there is under sensing of the QRS complex. Because if this QRS complex would have come here, then the next pacing spike would have come only after the predetermined time delay. It can never come on the T wave here. So that means it's not sensing these QRS complexes properly, and you need to decrease the sensitivity to make it sense the QRS complexes properly. What is the problem here? Anybody? What is the problem here? So the sensing, again, let's look at this. There is some pacing spike here. There's a P wave, yet there's a pacing spike followed by an AV delay. There is another pacing spike, and that leads rise to a QRS complex. So obviously, this is probably this is a DDD mode. So you can see that even if there is a P wave, still there has been a pacing spike after that also. That means that there is atrial undersensing. You can see that here also there is a P wave. Still, it leads rise to a atrial complex, followed again by the AV delay, and then the ventricular pacing spike, followed by the QRS complex here. Here again there's a P wave. Here again there is a pacing spike for the atria. So this is atrial undersensing, which has occurred in the DDD mode. Okay, what do you think is the problem here? So let's look at this. Here, there is one pacing spike followed by a QRS complex. Almost at an equal distance, equal interval, there's another pacing spike followed by a QRS, another pacing spike. So these are all at the same time. Here, there is nothing. There's a big gap. What do you think has happened here? What do you think has happened here? Again, the same thing, again, with the same time interval, the QRS complexes are generated, but here there is an absence of a pacing spike, probably because of all these activity. The pacer is now over sensing it. The pacer feels that this is also probably an electrical impulse and did not deliver a pacing spike here. So there is actually no electrical impulse. This is coming from some other source, like say the patient may be shivering, or it may be coming from some other thing or some random movement, but it's detected by the pacer as an intrinsic electrical signal, and the pacer does not fire here. Therefore, there's a big gap here between this complex and this complex. What is the problem here? Anybody? So these are the pacing spikes. You can see that there's a failure to capture. So here the pacing spike has generated this QRS complex. Here this pacing spike has generated the QRS complex, but here this pacing spike has not generated a QRS complex. Again, there is a de novo intrinsic activity. So because it's a synchronous mode, there is no firing of the pacemaker. Again, the timer is reset from this point. So the pacemaker will wait for the predetermined time, and it doesn't sense another intrinsic activity, and it fires here, but there is no generation of a QRS complex. So intermittently, there is loss of capture. So what is the solution in this case? What should we do? Anyone? I'm not sure whether you can unmute yourself. If you can, try the answer. Okay, so you increase the output, you increase the current that you are going to deliver to the myocardium in an effort to ensure that there's a 1:1 capture. What is the problem here? Any idea? So again, you can see there's a pacing spike here, followed by a QRS complex, pacing, QRS, pacing, QRS. You can see small pacing spikes, but you can't see a QRS complex. There's a big gap between the next pacing spike and the QRS complex. Again, there is a big gap here. You can see the small pacing spikes throughout, but there's a brief period of asystole. So again, that's a loss of capture. Here. Okay. So this again is under sensing. You can see that this is again the DDD mode, but even if there's a P wave here, still that leads to generation of a pacing spike for the atria. So that means that it's not sensing the atrial P waves properly. So that's again a case of under sensing. So I'll just leave you with a few videos. And once again, I thank Koshi sir for these videos. What is the mode of pacing here? Anybody, what is the mode of pacing here? Okay, your answer will be better if you see. Now, can you tell me what is the mode of pacing? Okay, so this is basically a ventricular mode of pacing. Why I say that is because you can see that there is a pacing spike followed by the QRS complex, and that leads to the cardiac output. But here there is cautery interference. Here there is cautery interference, but you can see that there is no drop in the invasive blood pressure. So that means that despite cautery, the output is constant, and that can only happen when you have an asynchronous mode where the cautery doesn't act. So that's the VOO mode. Okay, what mode is this? Manoj, are they able to unmute themselves or they are not able to unmute themselves?
Yes, sir.
Okay, so then nobody is wanting to attempt an answer. Okay. Anybody who wants to attempt an answer, what mode is this?
Satyajeet,
yeah,
you have to call them up by name, otherwise nobody is going to come forward.
I do not know the names. So Jebin, can you tell me, because you have the next presentation?
Atrial pacing, sir.
Okay, that's good. Atrial pacing. Suppose you're not able to, because it's set at a very fast rate and you're not able to clearly know that, you just increase the sweep speed. Once you increase the sweep speed, you'll be able to see the pacing spikes followed by the P wave. And so you know that's an atrial pacing. What mode is this? This is very easy. Okay, somebody else. I'm not sure who are residents and who are not here.
So this is atrioventricular mode.
Sorry?
Atrioventricular mode. Biventricular.
Not biventricular. It cannot be biventricular.
Atrioventricular.
Okay, so what do you call that mode?
Heavy sequential.
So you call it a DDD mode.
DDD.
Yeah, you call it a DDD mode. Okay, so so here you have both. Of course, so you have both the atria as well as the ventricle, which are both sensed, paced as well as sensed. Okay. Thank you. I think it's been an extensive talk, and thanks a lot for hearing me out. My talk is ended, so we can move on to the next presentation.
Okay, thanks so much, Satyajeet. It was a very detailed presentation. Now, students, if you have any questions regarding temporary and permanent pacemakers, it is the time to ask sir now, because we won't get time to come back to pacemakers later. We have a very busy schedule for the coming days. So any question you have, please ask now.
Okay, so let me ask a question. Let me ask a question and see how many of you have understood it. Suppose to make a pacemaker more sensitive. So do I increase the sensitivity or do I decrease the sensitivity? More sensitive means I want the pacemaker to sort of pick up very small electrical signals, intrinsic electrical signals. So do I increase the sensitivity? Do I dial up the sensitivity? Or do I decrease the sensitivity?
Aparna, Gargi, why don't you come forward? Answer the questions. It's better for the exams.
I could not hear that. I could not hear that.
So we decrease the sensitivity make the pacemaker more sensitive.
Yeah, okay. Decrease the sensitivity. What is the downside of decreasing the sensitivity too much?
Sir, it will pick up all the electrical signals that are generated, even
Not the electrical signals. It will pick up any sort of signal. Say the patient is shivering, even that will be interpreted as an electrical signals. So it's not going to pick up. It's going to pick up any random signal, including noise. If you are decreasing the sensitivity too much, it will also pick up the noise. That means that the non-electrical signals, which may be mistakenly interpreted as electrical signals. And what is the flip side to that? So suppose the patient is pacing dependent, you can have a loss of pacing and the patient can go into an asystole. Okay.
Okay, sir. Okay, sir. Yes.
Right. How do I convert? How do I convert? Okay, this is complicated. It may not be possible for you to answer. But how do I convert a VDD mode into a VDI mode? Okay, fine. It's not important. Any doubts you have? I can take that. Any doubts you have? I can take that. Okay, I think Rahul, there are none. I hope that you all enjoyed.
Yeah, I agree with you. I mean, there is another presentation after this.
So we'll move on.
Doubts, they can come back later. So, Jabin, would you please like to share your presentation?
Am I audible?
Yes, you are audible and we can see your presentation.
Good evening, everyone. I'm Dr. Jabin, and today I'm talking about automatic ICDs. So, image showing AICD. Today I'm talking about AICD in the following topics like introduction, evolution, indications, contraindications, the components, the types, functions, implantation, pre-op management, and complications. Introduction. Ventricular fibrillation is common cause of sudden cardiac death. Success with the external defibrillation led to the development of implantable defibrillator. Because of its high success rate in terminating VF or VT, the AICD has emerged as one of the therapies to treat patients with life-threatening ventricular arrhythmias. Evolution. In 1970s, Dr. Mirowski and Morton Mower and their colleagues developed the concept of implantable device that could automatically monitor, analyze cardiac rhythm, and deliver defibrillating shock when it is detected ventricular arrhythmias. After years of testing, in 1980, the first clinical implantation was performed. Over the past 4 decades, it has evolved from its most primitive form to the sophisticated device capable of tiered therapy and data storage. Indications. The indications are divided into intended for secondary preventions or primary preventions. The secondary preventions, it's categorized as class 1 and class 2A. Class 1, the survivors of sudden cardiac arrest due to VT or VF are those with hemodynamically unstable VT or with stable sustained VT not due to any reversible causes, or in an unexplained syncope in a patient with ischemic cardiomyopathy with inducible VT on electrophysiological study. The class 2A indication is like syncope presumed to be due to ventricular arrhythmias in a non-ischemic cardiomyopathy patient who does not meet any ejection fraction criteria for a primary prevention of a sudden cardiac death. The primary prevention, it is categorized as class 1, class 2A, and class 2B. The class 1 indication is that in a ischemic cardiomyopathy or non-ischemic cardiomyopathy with EF less than 35% and NaOHA class 2 or 3 heart failure despite any goal-directed medical therapies, and people with EF less than 30% in ischemic cardiomyopathy with NOHA class 1 heart failure despite GDMT. And people with ischemic cardiomyopathy with non-sustained VT with EF less than 40% with inducible sustained VT or VF on electrophysiological study. And class 2A recommendation is that non-hospitalized patient with class 4 who are heart failure who are candidates for cardiac transplantation or an LVAD. Class 2B recommendation is that any patient with non-ischemic cardiomyopathy with EF less than 35% despite goal-directed medical therapy and on NOHA class 1 heart failure. The same indications like primary prevention and secondary prevention was put on the algorithm. ACD, which are conditions where the ACD is not indicated. The patients with ventricular tachyarrhythmias due to completely reversible causes in absence of any structural heart diseases like electrolyte imbalance, maybe due to any drugs or due to any trauma, or patients who do not have any reasonable expectation of life, like survival of life with acceptable functional status for at least a year. Patient with incessant VF or VT in whom other therapies like ablation can be considered first, or patients with severe psychiatric illness that may be aggravated by device implantation. The other patients who are not indicated are the patients with NOHA class 4 heart failure who are refractory to any medical therapy and are not candidates for cardiac transplantation or ventricular assist devices. ACD implantation should be delayed in patients with active infections or any other acute medical issues. And patients with syncope without any inducible ventricular arrhythmias on electrophysiological study and without any structural heart disease. In these patients, the ACD is not indicated. Types. The types of AST may be of transvenous, subcutaneous, and wearable types. Coming on to the subcutaneous ICDs, these are preliminary meant for patients with difficult venous access or for complex cardiac anatomy. In this subcutaneous one, the lead is placed subcutaneously in the midline, connecting to a pulse generator in the left axilla. The device analyzes and treats ventricular arrhythmias by delivering an 80 joules biphasic shock. The anticipated battery longevity is shorter than the conventional AACDs. The pacing capabilities are limited to only post-shock pacing only. This is the image showing the subcutaneous AACD with the pulse generator in the left axilla and the lead moving onto the midline, subcutaneously into the midline. The advantages of subcutaneous AACDs are decreased risk of lead-related complications and easier re-interventions and lack of systemic dissemination in case of any device infection. The limitations are inability to provide chronic pacemaker activity. The pacemaker activity is limited to post-shock pacing only, and it's not indicated in patient requiring biventricular pacing for CRT. The wearables automatic defibrillator these are external defibrillator attached to the wearable vest. It is indicated in patients with transient with high risk for VT or VF, like the patients with permanent ACD that might be expanded for any reasons like device malfunction or any infection, and as a bridge until the ACD is implanted, like during the 40 days waiting period for post MI or 90 days waiting period for post myocardial revascularization. And candidates for AACD who are at high risk of infection or on any antibiotic therapy, or patients with newly diagnosed non-ischemic cardiomyopathy with severely reduced LV systolic function that is potentially reversible one. This is the image showing the wearable cardiovascular defibrillator with the wearable vest in which the external defibrillator is attached to it. Limitations of wearable ones are it cannot provide any anti-tachycardia pacing. So the rate of shocks will be more with the wearable ones, and wearable ones cannot perform the function of a pacemaker. So some patients may not have a good body habitus, so it may act as an external noise leading to inappropriate shocks. The device must be removed for bathing, so there is no protection afforded when the device is off. The transvenous one. In the transvenous one, the pulse generator is inserted subcutaneously or submuscularly, and the leads are inserted transvenously, and depends on the single chamber system or bi-chamber system. The leads may be in the RA or RA and RV. The components of ACDs are the pulse generator, pacing and sensing electrodes, and the defibrillation electrodes. Pulse generator. The pulse generator contains the sensing circuitry as well as high voltage capacitors and battery. It is made up of titanium ones. The majority is placed in the subcutaneous position. A pulse generator will last for 5 or more years in most patients. Pacing and sensing electrodes. Usually use leads with 2 electrodes. The distal electrodes are the tip of the lead and the second electrode in the shape of a ring several millimeters back from the tip. These bipolar leads provide accurate sensing with high amplitude narrow electrograms. Bipolar leads reduce the risk of extravenous interference. And defibrillation electrodes. The contemporary ACD system use coil of wire that extends along the ventricular lead as a preliminary defibrillation electrodes. Additional defibrillation electrodes improve the defibrillation efficacy and reduce the defibrillation threshold. Thus, a single transvenous lead can accomplish all actions like pacing, sensing, and defibrillation function of an ACD. Implantation. Prior to implanting an ACD, the provider must determine the optimal position for placement of the leads and the pulse generator. It intends first choosing the optimal pulse generator location, second choosing the optimal lead position placement, and third the defibrillation threshold testing. Coming on to the choosing the optimal pulse generator location, implanted in the pectoral region in the anterior chest wall, either subcutaneously or submuscularly. The left pectoral region is preferred for 2 reasons, like defibrillation energy requirement is usually lower in the left region because of location nearer to the heart, and second one is there is always a small risk of arm swelling due to venous occlusion, which may impact fewer people in the left as majority are right-handed. Choosing the optimal lead placements. It may be of single chamber systems or dual chamber systems or 3 lead system like in CRT. In single chamber system, the lead only in the RA only have the RV lead. The dual chamber system have leads in the RA and RV, and CRT have leads in the RA, RV, and LV. This is an image showing the single chamber and dual chamber ones. The single chamber ones have the leads in the RV, and dual chamber system have the leads in the RA and the RV. The advantages of the single chamber versus dual chamber ones are: single chamber ones reduce rates of complication related to the placement of atrial lead, such as dislodgements or any lead perforations. The dual chamber ones improve discrimination between the atrial and ventricular arrhythmias to avoid inappropriate shocks and the ability to provide atrial pacing. Defibrillation threshold testing. The test involves inducing VF under controlled conditions to ensure the device senses, detects, and terminates the arrhythmias reliably with adequate energy delivery. Contraindications for DFTR documented in a cardiac thrombus, atrial fibrillation or flutter without adequate anticoagulations, severe aortic stenosis, unstable angina, recent stroke or TIA, or any patients with any hemodynamic instability. Anesthesia consideration for implantation of ACDR. Usually, the insertion of ACD
I'll
is
just stop you for a minute here, Jabin. I'll just stop you for a minute here. Can you go back to the contraindications? So yeah, look at point number 3. Why severe aortic stenosis is a contraindication?
Sir, in severe aortic stenosis, any tachycardia is not acceptable in severe aortic stenosis, sir.
No, we are talking about contraindications for placing an AICD, right?
Not an AICD, sir. For defibrillation threshold testing, sir.
Testing. Okay, fine.
Yeah, yes, sir. Can I move on, sir?
Yeah, please continue.
Anesthesia consideration for insertion of ACDR, usually it is performed in the catheterization suite. In addition to the ASA monitoring, invasive blood pressure monitoring may be considered. And external adhesive pads are placed before the procedure and connected to the external cardioverter defibrillator to provide backup shocks if the device is ineffective. Typically, monitor anesthesia care is chosen, but short-acting general anesthetic may be given at the time of defibrillation threshold testing. General anesthesia may be chosen for patients with severe concomitant diseases when the control of the airway is desired. The therapy is provided by the ICDR. The ICD therapies are programmed to ensure maximum patient safety. The device continuously senses, analyzes native electrical activity to detect any VT or VF. If any VT arrhythmias are detected, the VT arrhythmias are detected by rate, duration, onset, and morphological criteria. ACD therapies are tired, like such that the device initially delivers a low threshold energy, which subsequently increases until the desired treatment is obtained. The typical order, like first ATL, anti-tachycardia pacing, followed by cardioversion, and finally a defibrillation. ACD is able to pace in the event of any post-shock bradyarrhythmias. The functions of ACD are ECG monitoring and storage, anti-tachycardia pacing, cardioversion or defibrillation, bradycardia pacing, and remote monitoring. ECG monitoring and storage. ACD can record and display the stored electrograms from any tachyarrhythmia events. This may be helpful for detection of any silent or asymptomatic arrhythmias where the management of patient is likely to change. Anti-tachycardia pacing or override pacing refers to use of pacing stimuli to terminate re-entrant tachycardias. This is an image showing ventricular tachycardia, the override pacing followed by the stop of the ventricular arrhythmias. Cardioversion, a shock that is synchronized to delivered at the peak of RVV is referred as cardioversion. Because VT is an ventricular tachycardia is an organized electrical rhythm. Synchronized cardioversion can often terminate ventricular tachycardia with relatively low energy, like 10 joules or less. This is an image showing ventricular fibrillation followed by a defibrillation shock. And below the ventricular tachycardia, in this, its synchronized cardioversion is done, followed by a post-shock rhythm. And defibrillation, because ventricular fibrillation is not an organized rhythm, synchronized cardioversion is not possible or not necessary. And unsynchronized shock is referred to as defibrillation. ACD is typically programmed to deliver unsynchronized shocks at energy approximating maximum output, like 32-35 joules. Bradycardia pacing. Many patients with ACD have conventional indication for cardiac pacing also. Separate ACD and pacemaker can produce device-to-device interactions, potentially resulting in inappropriate shock and underdetection of ventricular tachycardia or ventricular fibrillations. In addition, it protects against bradyarrhythmias. It can follow tachycardia or a shock. Remote monitoring. Majority of ACDs are now capable of remote patient monitoring. This allows for closer monitoring of the patient between office visit as well as potential for early intervention if device malfunction or clinical deterioration is detected. Remote patient monitoring is associated with lower risk of mortality and rehospitalization. Complication associated with the ACDR, it's divided into device related and therapeutic related. The device related to it are infection or any erosion, hematoma, pneumothorax, lead dislodgement malfunctions, inadequate defibrillation threshold testing, or connection issues. Therapy related are frequent shocks that may be appropriate or inappropriate and psychological issues. And these are the anesthesia consideration during patient coming on for any non-cardiac surgery. The patient with the ACD coming on for any non-cardiac surgeries. Preoperatively, we should look on for the symptoms related to device malfunctions like dizziness, syncope, or any indicators for deteriorating of the cardiac function to be made. And recent electrocardiogram should be available. And the ACD should be distinguished. Chest X-ray should be done to distinguish any ACD from the pacemaker or any lead fracture or a lead migration. Every patient should have an in-hospital comprehensive evaluation every 3 to 6 months. Knowledge regarding the model type, dependency, magnet board, and the electromagnetic interference potential to be known prior to anesthetic patient for with ACD for non-cardiac surgery. Preoperatively, any electrolyte abnormality, acid-base disturbances, or blood gas disturbances should be corrected since it may influence the stimulation or defibrillation thresholds. The surgery involving electromagnetic interference unlikely, no additional interventions are needed. the surgeries involving electromagnetic interference likely, we should suspend any anti-tachycardia therapy. If this is not possible, application of magnet should be considered. Intraoperatively, standard monitoring and the ability to deliver external cardioversion or defibrillation must be present during the time of AICD disablement. Caution should be observed when placing a central venous catheter in any patients with AICD. It may act falsely observed as an electromagnetic interference and inappropriate shock may be delivered. Anesthesia should be delivered to patients' cardiac state, existing comorbidities, and intended surgical interventions. And negative inotropes should be avoided, try to be avoided, and the positive inotropes may precipitate any tachyarrhythmias in susceptible patients. Electromagnetic interference. In case of AICDs, electromagnetic interference may be falsely interpreted as shockable rhythm. There is a risk of intraoperative shock delivery. Disabling the defibrillating function of a device before the exposure to electromagnetic interference is therefore advised. This is an image showing the electromagnetic interference followed by a shock post rhythm. Hospital sources of electromagnetic interference are extracorporeal shortwave lithotripsy, electroconvulsive shock therapy, radiofrequency ablation, TENS unit, TURP procedures, and electrocauteries. Magnitude in cases of MRI, before the MRI, interrogate the AICD, suspend anti-tachycardia function. In modern devices with the MRI conditional AICDs, program to MRI mode. If there is a need of any hemodynamic instability requiring cardioversion or defibrillation, move the patient out of the MRI scan area, use the external monitor, cardioverter, and defibrillator. After post completion of the MRI, reintegrate the AICD. Magnet on AICD. It is possible to deactivate the defibrillation function of the AICD in emergency situations by placing and securing a medical grade magnet on the device for the duration of the surgery. Magnet application will not affect anti-bradycardia pacing. Intraoperative emergencies. In case of any intraoperative emergencies, before attempting emergency external defibrillation or cardioversion of the patient, magnet applied should be removed to permit reactivation of the AICD anti-tachycardia function. Also, all sources of EMIs should be discontinued to ensure correct rhythm interpretations and appropriate shock therapy. If magnet removal is not immediately successful, and external defibrillation should be employed. If there is a scenario of cardiac arrest, initiate CPR, defibrillate the paddle position to be at least 13 centimeters from the device, and apex to posterior position can be the defibrillation paddles can be applied. Evaluate the device when the patient is stable. If the patient is having AICD, the device will attempt to treat the arrhythmias. You may feel a slight shock on touching the patient. Post-operatively, patients with the AICD are ideally managed in high dependency recovery environment with continuous monitoring and full resuscitation equipments immediately available. The defibrillation function of AICD, which has been suspended, needs reactivation by cardiac physiologist after surgery. Thank you.
Okay, thanks, Jebin. Please remove your presentation. And I would request Satyajeet to ask a few or moderate this presentation in light of examinations, whether if you want to ask any questions, etc.
Yeah, Jebin, that was a good presentation. You have quite comprehensively presented the starting from the history down till what should be the post anesthesia care for these patients. I just thought that similar to the codes for pacemakers, there exists codes for the AICD devices also. Are you aware of the codes? And they are called the NBD codes. Can you tell what the codes are?
No, sir, I am not aware, sir. I will check into it.
Okay, so while you do that, that's your homework. But any other participant here would like to tell what are the various codes? Anybody? Okay, so like the pacemaker, where you have the chamber that is paced, the chamber that is sensed, and what is the response. For the AICD also, you have similar codes. The first chamber, it refers to what is the chamber that is shocked. Okay. So if your atrium is being shocked, then it will be A. If your ventricle is being shocked, then it's going to be V. Or if both the chambers are going to be shocked, then it's going to be D. The second position again refers to where the antitachycardia pacing is delivered. For example, if it's the atria where the antitachycardia pacing is delivered, it will be A. For the ventricle, it will be V. And similarly, if for both the chambers, the antitachycardia pacing is delivered, it will be D. The position 3 is by what means the arrhythmia is detected. So basically, it means that whether it's detected by the means of an ECG, or whether it's by hemodynamic instability that the arrhythmia is detected. So that's how the position 3 is. And the position 4 is basically something for the pacemaker capability. I'm not very sure what it means, but this is for the pacemaker capability. So like you have for the for the AICD capability. So like you have for the pacemaker, the NBG codes, for the AICD, you have the NBD codes. So it's important that you understand and you remember the codes, because they can be a short note in the exams. Okay, so basically on an X-ray, how will you distinguish whether the patient is having a pacemaker or having an AICD? Suppose you don't have access to the patient's other medical things, like you don't have access to the card where the patient has where it's declared what type of device it is, or so on and so forth. So from the X-ray, how will you know whether it's a pacing device or whether it's a device with defibrillating capabilities?
The position of the leads, sir.
So you will have if it's the leads will be in the same position. For the dual chamber pacemaker or for the dual chamber AICD, you'll have atrial as well as ventricular leads. So that will not differ.
The leads will be usually thicker, sir.
Yeah.
For defibrillation.
For
defibrillating electrodes.
So because they have the basic function of the leads is to shock, so they'll be much thicker. Whereas the pacing leads, they'll have the thickening restricted to the tip of the pacing. So we will have these thickening restricted to the small part of the tip of the pacemaker. Whereas for the AICD, it will be a longer length of the device that will have a longer length of the lead that will have thickening. So those are the two questions. Otherwise, you've covered in detail. So let me ask you: suppose a patient has got an AICD device, and intraoperatively you need to put in a central venous catheter. Where would you plan a central venous catheter? Say, for example, he has a dual chambered AICD device from the left subclavian system.
Intraoperatively, sir, we can put on the femoral one, sir.
Yes. Since it's one of the things that an AICD can do while you are attempting a central line, is that it can detect these when you're putting the central line at the tip of the SVCRA junction. Those transient arrhythmias can be misinterpreted by the AICD as some sort of arrhythmia and then shock the patient. So it's always a good idea to put it at a site which is quite remote, and preferably at the femoral veins. So that is one thing that needs to be done. What else? So I think these are the important things. Any anesthetics that would be contraindicated in such a case? How do you position these patients? For example, if you want the lateral decubitus position. Yeah, if you want the lateral decubitus position, say for example, the patient is undergoing, let's say, thoracic surgery, and you want to put the patient in left lateral decubitus position. Any special consideration while you're positioning these patients? So it's always a good idea to sort of put some protective pads around these, because it's what it does is it just sits in a subcutaneous pocket. Okay, it sits in a subcutaneous pocket, and if we are not careful with positioning these patients, So again, there can be a chance of a lead fracture or something like that. So it's very important that we gently position these patients in, suppose it's a supine position, that's fine, but other positions like say prone or let's say lateral positions, then we need to be careful about how we are positioning the patient. And I think we should take extra care and caution while positioning these patients, and definitely pad these areas so that it prevents pressure on the pulse generator as well as prevents lead fracture. Okay. So these are the questions. Rahul, I think he has fairly extensively covered it. So I think I'm done.
I agree. I mean, Jebin has done a fantastic job, very comprehensive presentation. Jebin, I just wanted to tell two things here. Just two additional points that I wanted to mention. One is that magnet, it is kind of a primitive therapy now in terms of disabling the AICD function. Why? Both for pacemakers and AICDs, magnets are known to interrupt or interfere with the internal circuitry. These devices are nowadays very modern and very sophisticated. So as much as possible, reprogramming before the operation is mandatory both for pacemakers and AICDs. And in most cases in hospitals where we are dealing in patients with pacemakers and AICDs, there are electrophysiology teams, there's the cardiology department. So reprogramming is not a big deal in most of these places. Of course, where you don't have these facilities, we have to think about magnet, keeping in mind that magnets can significantly hamper functioning of these modern devices. That's one. The other thing in your presentation I wanted to comment on was, in case you need to give external defibrillation in a patient with already in situ AICD, in an emergency, you really don't have to bother about how much distant the paddle is from the AICD. You can even put it on the AICD as per as the American Heart Association guideline. The idea is more importantly to defibrillate. Rather than spending time to find out the exact way in which it should be defibrillated. These are minor points, but otherwise you have done a very good job in presenting AICD. The other students, would you want to clarify any doubts, or you have any questions regarding AICD? You can ask Dr. Satyajeet or me in this situation, because we'll be moving forward and going to the other parts of cardiac anesthesia. Any questions if you have?
So just to add on to your comment, the magnets are not good because it's very tricky to retain their positions intraoperatively, because you need to strap it on. So any change in position or anything, the magnet is easily going to slip off, and the whole idea of putting the magnet will be lost for the patient. And B, the second comment is that what you said is absolutely correct. If an emergency defibrillation is required, then that takes priority, because many of these modern AICD devices are actually, they are well cushioned against shocks. So the moment a shock is delivered externally, the device sort of recognizes that the patient is being shocked and has some protective armory. I'm not exactly remembering what it is called. It's called a Zenate diode or something. That protects these AICDs from external defibrillation. So we don't need to worry too much about where we are putting the paddles and shocking the patient.
Absolutely. And okay, great. I think we had a wonderful session today. Thanks to both Satyajeet and Jebin, for Satyajeet for presenting and explaining in details the usage of the temporary pacemaker. A, for all of you to use it properly in the operation theater, and B, it can always come as an instrument in your Viva table, and all the things that Satyajeet sir explained to you all will be asked in the examination. And Jebin, thank you for a very detailed presentation. So we will conclude the session today, thanking both of you, and we will again meet. Yeah, great. We'll again meet after a fortnight. Thank you so much.